Bismillah ar-Rahman ar-Rahim. Good morning, ladies and gentlemen. Good morning, Mr. Sharif, Executive Directors, and my staff colleagues. It's my pleasure to introduce to you the monthly General Staff meeting of the 3rd of June for 2021 for King Fahd Specialist Hospital. We'll be starting with the beginning of Mr. Sharif's speech. Please, Mr. Sharif.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. Thank you all for joining us today in the room and online. We have a lot of good topics to cover today, primarily to give you updates of different things that are going on throughout the hospital. And then obviously at the end of the session, we've, alhamdulillah, received lots of questions from our last town hall, I think over 30 questions. Many of them have similar themes, so we'll try to summarize them and go through them more in the themes. And then today I'm happy we have lots of appreciations from recognitions of the great job that our clinicians and admin staff have done over the past quarter and the patients recognizing them. So we'll get started today with the first on clinical pharmacy.
The first topic with us today, clinical pharmacy in call. Dr. Noor Al-Ashi, the Deputy the Pharmaceutical Care Services Administration, she will be present this topic. Please listen.
Good morning, everyone. Thank you for giving us this opportunity today to introduce our new service. I'm Noor Al-Ashi, solid organ transplant clinical pharmacist. We have established a clinical pharmacy on-call service to improve our patients' outcome, to improve medication safety, and to provide any medication-related information to other healthcare professionals. So it's a 24/7 service. We are providing responses to clinical inquiries and therapeutic drug monitoring. So if you have any clinical question, you can just reach clinical pharmacists and they can help in formulating therapeutic plan with the latest updated evidence, and we can help by providing medication-specific information in regard of dosage, administration, interactions, and monitoring. Also, clinical pharmacists can help in suggesting alternative therapeutic options. The second task of the on-call clinical pharmacist is to perform therapeutic drug monitoring, which is a clinical practice of measuring specific drugs concentrations at patient bloodstream at specific intervals to ensure safety and efficacy. So we apply this therapeutic drug monitoring to specific medications with narrow therapeutic index, drugs with marked pharmacokinetic variabilities, and medication of which target concentrations are difficult to achieve. So we're performing this service by following all patients actively on specific medications. We review all patients' profile and clinical relevant data we need, and finally we'll formulate our therapeutic plan according to this. After that, we'll be delivering this recommendation to the primary team and documenting it in patient profile. In phase 1, we started our service covering vancomycin and aminoglycosides medications. After that, we'll be covering all anti-epileptics and immunosuppressant medications and others. So our first on-call are our clinical pharmacy residents, and the second on-call will be the senior clinical pharmacist, and we will be performing a competency assessment in regular intervals to ensure our staff competency. So we'll have this clinical pharmacy on-call poster distributed over the hospital, and this is our on-call number. You can call us 24 hours, we are here to help. Thank you.
Thank you, Dr. Noor. And now we'll be with the second topic with us today. It will be the new King Fahd Specialist Hospital identity. And will be with us Mr. Misfar Al-Gahtani, the Director of Corporate Affairs Administration.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم جميعا بكل خير. اليوم هذا مختلف، يوم تكاتفت فيه الجهود من الجميع لانطلاقة جديدة. اليوم نحتفل بإطلاق الهوية المطورة لمستشفى الملك فهد التخصصي بالدمام، والتي كانت نتاج عمل أشهر، وكانت نتيجة إلى حاجة لتوحيد المخرجات وتحقيق تطلعات الإدارة العليا بما يتماشى مع رؤية المملكة 2030 والتحول في القطاع الصحي. قمنا بعمل تحسينات متنوعة تساعد الجميع إلى إتمام جميع الأعمال بصورة واضحة ومتميزة. حرصنا على أن يكون كل شخص لديه الوصول إلى الملفات الهوية بكل تفاصيلها وتطبيقاتها. قبل البداية واستعراض الشرائح، اسمحوا لي أن أتقدم بالشكر لسعادة الأستاذ شريف عدنان عمر رئيس التشغيل، وإلى المهندس ظافر المبارك والدكتور هليل الحربي والأستاذ خالد الجندان لدعمهم الدائم ومتابعتهم لهذا المشروع. والشكر موصول لجميع الإدارات والأقسام التي تعاونت معنا خلال فترة العمل، كما أعرج بالشكر لزملائي في إدارة التواصل المؤسسي لجهودهم وعملهم المتواصل خلال الفترة الماضية. نستعرض جميعا الضوابط العامة للهوية. بسم الله نبدأ. كما ترون فلسفة الشعار، وهي تحمل شعار الوطن، النخلة والأيقونة للرعاية الطبية التي تحمل الهلال ودلالتها الرعاية الطبية. ننتقل إلى ألوان الشعار، وهي لونين معتمدة، اللون الأزرق واللون الذهبي، وكذلك الألوان الثانوية كما ترونها موجودة على الشاشة. استعرضنا كذلك الاستخدامات الصحيحة للشعار وموجودة كما ترون على الشاشة، كذلك الاستخدامات الخاطئة. وانتقلنا كذلك إلى الخطوط المعتمدة باللغتين العربي والإنجليزي كما ترونها موجودة، وبالتفصيل في استخدامها في العنوان الرئيسي والفرعي، وكذلك المطبوعات بجميع احتياجاتها كاملة. وانتقلنا كذلك إلى النماذج الداخلية لما لمسناه من حاجة في الباوربوينت واستخداماته بشكل دائم كما ترون موجود على الشاشة كذلك. وثم انتقلنا إلى التطبيقات الخارجية للموقع وللصفحات كما ترونها موجودة الآن. نشكر الجميع ولحرصهم في تطبيق الهوية، ويسعدنا جميعا أنا وزملائي في إدارة الشؤون الحكومية والتواصل المؤسسي للاستفسارات ومتابعة تطبيقها بأي وقت. اسمحوا لي أن أستأذنكم جميعا دعوة الأستاذ شريف لتدشين الهوية، فليتفضل مشكورا. جميعا والله يعطيكم العافية.
Thank you, Mr. Misbah. Now we'll be with YTD progress, and Mr. Sharif Adnan Umar, the Chief Operating Officer, he will present.
Let's, we can cover the discharge. I'll do the discharge lounge.
You want to
Right.
cover it? Okay.
Right.
So do you want me to?
Yeah, go discharge.
This is the
Right. Assalamu alaikum again. For the discharge lounge, this is a topic and a function that a large group of people worked on within the hospital. It was a cross collaboration between nurses, physicians, technicians, allied, you name it, the whole food, nutrition, everybody. And the purpose of the discharge lounge was to figure out a way to how we can improve the patient flow within the hospital. So you can see we've had, as you know, over the years, a struggle with accessing beds. And there's nothing more frustrating, I think, to everybody in the hospital when you spend maybe 2-3 hours of your day trying to figure out how do I create a bed for a patient so that we can do the surgery or so that we can admit them from the emergency room or whatever the case may be. And so we charged this group to say, okay, come up with various solutions on how we can do this. And so there was, through the process improvement, lots of different recommendations. One of the recommendations was to develop a discharge lounge. The reasons why patients are waiting within our hospital, the number one reason is they're waiting for personal transport. So the physician has written the discharge order, cleared the patient, pharmacies delivered their drugs, nursing's done all the discharge education, and then they sit in the bed for 4, 5, 6, 7 hours more, waiting for their transportation to come get them. So you can see the various different issues that occur due to discharge. None of them are clinically related. It's all more social related issues that allow us to should allow us to care for someone in a different area. So the discharge lounge can help bridge the gap between the acute admissions and those returning to the community. Patients sent to the discharge lounge opens an available bed so that we can get new patients in there. So remember, we're not talking about a person that's sick. This is a person that we as a healthcare facility have taken great care of, and they're safe enough to go home. So if they're safe enough to go home, they should be safe enough to sit in an area, a comfortable area within the hospital, and still be monitored by a clinician just to make sure that there's no risks embedded. But if they weren't in, if their ride had showed up at home, they'd be sitting on their couch or laying in their bed at home. So there's no reason that we can't create a separate area for them that's comfortable to wait for their transportation. The goal of today is to begin to promote the discharge lounge so that we can get a better utilization of it. Honestly, the lounge has been open for probably a month and a half now, and we've had very, very little utilization of the discharge lounge. And the reality is, for us to continue to resource this and make it successful, we need all the clinical support to ensure that patients, once they're identified and cleared for discharge, we begin the process of moving them downstairs so that we can free up beds, so that we can move, whether it's an emergency room patient, a surgical patient, whatever the case may be, but a patient that is in dire need of actually being in an inpatient bed. Smooth transition from the hospital to other specified destinations, wherever that may be, improved utilization of the discharge lounge, timely availability of bed for inpatient wards, and then the aim for patients to have a positive and comfortable. The discharge lounge is right outside of the main auditorium. Anyone can go in there and see. We've tried to make the chairs comfortable. We have refreshments there so that if someone does have to sit there for a period of time, they feel like they're part of the, they feel comfortable. We are also in the process of renovating the 2 bathrooms right next to the discharge lounge. As we know, many of our bathrooms are old and outdated, and there is a project to replace all the bathrooms, but we started with these 2 initially to make sure that, again, the experience is not a negative experience and that it's a positive experience for the patient. Again, those people that are eligible will be patients that are discharged. So they've been, discharge orders have been written, all the items have been cleared. We do have the ability, since there will be a nurse in the discharge lounge, that will have access to MCC, that if there is on an occasion where a person's prescriptions haven't been delivered to them in their inpatient room, we will have the ability to deliver them in the discharge lounge, and the nurse is there to ensure that the patient doesn't leave before they receive their medication. Ambulatory patients, mainly people waiting for a home. The important thing is we want to keep it a safe environment, and we don't want to put people in there that may create an unsafe environment. So you can see palliative care patients that may be vulnerable or not allowed. Patients are waiting for transfers by paramedic. So clearly, if they require an ambulance transport, they're probably not the right fit for a discharge lounge. Confused patients, patients with infection, especially during this age, we have to be very, very careful that again we have a safe environment. Bedridden patients and patients who need respiratory support. There's a policy that's out there that clearly identifies these protocols and procedures for managing patients. So again, I just want to encourage everyone to support the effort. I know how much time case management, social workers, the nurses, the physicians spend every day looking for beds. The lounge is able to accommodate 6 to 7 people. So if every day we can free up 6 or 7 beds, that creates a huge win for the entire hospital, and will save you unproductive time and allow you to practice clinically at a higher level instead of just sitting around waiting for a resource to appear. So again, this won't work unless we have all the clinical people support, and so we're here today to encourage everyone. If you have any questions, Mr. Abdullah is available. If you want to see the lounge, feel free. The room is open. Feel free to see the environment that we created for our patients. Thank you.
Thank you, Mr. Sharif. Now, the second topic of you will be the YTD progress.
Over the course of the past several months, the cluster has been working with all the different hospitals to come up with standardized metrics that we can look at to measure our operations. How are we performing from a day-to-day operating standpoint? And so they came up with a list of standardized categories for every hospital within the cluster. And then based off historical performance, specific targets were set for each hospital. So I wanted to review today so far our progress through the first 4 months of the year. Obviously we're already in June, halfway through the year, and I can tell you, and we'll see, that we've done a good job so far managing to many of the metrics. There's a couple of items that we're behind, and we'll put the effort in over the next 6 months to ensure that we achieve all of our targets. This will be the cluster will be identified in here. It'll be part of the new transformational contract with FOB or with CNHI, the new payer, that says, okay, these are the operating metrics that you say you're going to achieve in order to continue to receive the consistent funding. We have to show improvement in performance. We as a leadership team will also be graded on our performance relative to these metrics. So the first one is the average length of stay, and many of these metrics are also duplicate in the ADAT. We tried to minimize adding more KPIs and see where we can utilize similar KPIs across the board. So you can see in our target for 2021 is 8.5. We're at 7.5. A lot of this is due to the efforts of all of our clinicians to work on discharging patients as quickly as appropriately as possible. what we just talked about, the Discharge Lounge is one of those items that is a new thing, so that we can continue to work on driving down our length of stay. Obviously, our length of stay is a little bit high, given that our patient population requires longer length of stay. And then we have, for example, the only real palliative unit throughout the cluster. And so those patients by default will be in the hospital longer. Most of the other hospitals, their targets for length of stay are around 4 to 4.5 days. So you can see that we're making good progress on there. OR utilization, I'm very confident by the end of the year we'll have achieved our target. Obviously, at the beginning of the year, with some of the issues around Corona and some of the OR issues that we had around the environment of care, we had to reduce the number of surgical cases that we were doing. But as you can see in the past couple of months, we are exceeding the target. One of the areas that we do need to focus on in the next 6 months is the percent of total surgeries to day surgeries. Again, you can see we've made some progress, but our target is at 30%. This is again a target that's specific to our population. The best practice and what the other hospitals in the clusters target is 70%. That 70% of their patients should be done as outpatient. But given that our patients have a much higher acuity, the majority of our surgeries will be inpatient. So you can see where our target is. So we just need to look at and continue to focus to identify potential patients that can be done as outpatient, as we have been, and shifting them. Again, one of the areas for transformation is how do we reduce the abuse of the emergency room visits. So patients that could be treated in primary care settings or urgent cares, so are usually falling in that CTAS 4 and 5 category. Again, we know we have a unique patient population, that these are many of our own patients, oncology patients, transplant patients, and so they come here because we have their file. But there are still a quantity of patients that come in for minor issues, whether it's a cough, cold type thing, that we do need to look at how do we bridge the gap to educate patients to move to urgent care. We also, I know in the past, and we need to revisit it, is looking at starting up our own urgent care within KFSH for our own patients that don't meet emergency room criteria, to be able to shift them into a KFSH-run urgent care. So again, we'll reevaluate and see how we can get back on track on that. I'll jump down to, you can see the UCC variances, but patients seem to disposition within 4 hours. Our target is 70%. Currently, we're at 65%. This is one that, as you know, is carefully monitored throughout the kingdom. It was a metric that His Excellency the Crown Prince mentioned in his interview, and it's really a focus to ensure that patients are coming into our emergency room and treated in a timely manner. We know that there are many obstacles and many challenges. But we've done some work, the emergency room has done some work with Philips, and they've also worked with the oncology team, since I think greater than 60% of our admissions are from oncology, to look at how we can streamline oncology admits out of the emergency room in a more timely basis. Some of the work is in the emergency room, but a lot of the work goes back to bed availability and discharging patients in a timely manner. So we have a pilot going on in one of the units where they have a new bed board where there's a daily huddle, multidisciplinary daily huddle. They look at the estimated days that a patient should be here, anyone that's over, and how do we discharge those patients. Again, that will help with length of stay, but it also helps with moving patients out of the emergency room in a timely basis. One area is that we really made good progress this year is OPD average wait times. You can see we're right at the target, and I'm confident with our new OPD strategy of standardizing the schedule. This target will not just be achieved, but be beaten. We've already looked at and implemented new standardized schedules within the cardiology section, and by implementing standardized schedules, we've increased our available slots by 15%. The next phase is the pediatric department will be implementing, and based off of the analysis that we have, we'll be increasing in pediatrics by 7%. So we know just by creating standardized processes and standardized schedules, we'll be able to open access, which will allow us to achieve these targets. Another area is home visits to admissions. And so what this really drives is within the clinical practice, as you know, getting patients out of the hospitals into their home is one, a satisfier for the patient, but also a better safety. You know, the longer they're in the hospitals, the greater chance of an infection or something else. So really utilizing home care to prevent readmissions of patients coming back to the hospital. But you can see we've done a good job of that, and you can see the total number of new care. So from a metric standpoint or operation standpoint, the areas of focus really for the next 6 months will be driving more patients into the into an outpatient setting, and then looking at how do we continue to educate our patients on the appropriate emergency room versus urgent care, primary care type follow-up. Moving into a pure volume standpoint, and you know, this is numbers that I know are still below the COVID target, but obviously we're still below historical targets, but obviously we're still living in the COVID world. But you can see our target for total number of admissions is 11,550, and based off of our current run rate, we're projecting out to be right at that number. And so I'm confident, knowing the obstacles that we had in the first 6 months, that we'll beat this target if we continue to do what we've done and improve access. Same thing with surgeries. You know, as you can see from the OR utilization, the first couple of months were down, but we've really made up some progress over the months after that, and so I'm confident we'll be able to achieve this as well. Outpatient visits, we're well ahead of the target. You can see our target is 337,000, and we're at 350,000. ER visits, you know, this is probably one that's a good thing to be down, right? Because we want to shift more patients into primary care into urgent care. And so this is an area that, you know, it's okay to be below the target as long as our patients are getting treated in the appropriate setting. So when I see outpatient visits go up and ER visits go down, that's a good correlation between the two different metrics. Another area is workforce planning. As you can see, in 2019, we had 3,755 employees. We went up to 3,834 in 2020. In 2021, we actually have a target that's higher than our historical run rate. Obviously, that's a good thing for us. But it's also been challenging this year just because of the hiring freeze, that we haven't been able to necessarily recruit all the clinical positions that we may need. We have gotten traction at hiring some physicians and nurses within certain areas, and then we've also recently were successful at getting an exception and hiring, I think, 6 pharmacy students into as pharmacists. And so we'll continue to work at getting specific exceptions because we understand that there are areas that have true need, and the resources are limited, and we do need to add. But then at the same time, there are other areas that we will continue to be more conservative in hiring. But you can see the different categories that have been provided for us, and we're achieving the targets. And as we begin to develop specific plans on areas that we're behind, alhamdulillah, our overall performance is very good. There's just a couple of areas that we need to refine and improve upon. But if we continue to do the things that we have been doing, inshallah, by the end of the year, we'll have achieved our goals and our targets. The next thing I'll talk about is committee structure. But so committee structures. I'll tell you. I'll start with. There's nothing I hate more than a meeting. I don't know that anyone truly enjoys meetings, and we know that, you know, not here in KFSH, but not in Saudi, but everywhere. Everyone, you know, the joke is, if you want something to die, send it to committee, right? And so this is not intended to do that. It's actually intended to do the opposite. And we'll go through the new structure, but more importantly, I wanted to go through the why of why we're doing this. Honestly, from my perspective, the most important thing for us as a hospital is really three different areas. One is there's nothing that we do in our day-to-day that shouldn't be. At the end of the day, if we can't support each other as a team, then we'll never be successful. And I know often there's this blame culture. You know, the first question is who did what and why did they do it, right? And this really shouldn't be the environment that we're in. We really should be part of an environment that says, okay, what happened? Was there a process issue? Was there a cultural issue that didn't, in the department that didn't support this? Or was it a accountability issue when someone knew the policy was there, the process was there, but someone just decided not to follow it, right? But we can't get there until we have a transparent environment, that data is shared across the board, issues are shared across the board, and positive outcomes are shared across the board. So transparency is the second one. And then the most important one for me, and I know the senior leadership team is probably tired of hearing it from me, is accountability, right? At the end of the day, accountability is not a negative thing. All it means is that two people are supporting one another, and there's an expectation that I won't fail you and you won't fail me. It's the premise and the baseline for teamwork is accountability. And so if I can't share the information or can't share the facts with you and can't hold each other accountable, then we will never be successful in advancing our initiative. And accountability is across the board, right? It's not just peer-to-peer. It's anyone should be able to say, you know, Sharif, you told me X, Y, Z, and you didn't do it, right? Or this is behind. And I don't get offended by that, because if I've told you I'm going to do something, then I should do it, right? And if I can't do it, I should be able to come back to you and say, listen, I know I told you I was going to do this, or I was going to do this by this date, and I can't do it, right? Or it's going to take me longer to do that. And so what we're looking to do is create a structure that moves away from a person, everything being dependent on one person or two people or three people, to a structure that has open communication and open accountability. So where we're moving from is the COO had 30 committees reporting to them and 3 councils. So let me tell you what this means. This means that there's only one person in the entire hospital that knows everything, which is never a good thing, right? We should have an infrastructure in place that the right people have access to information and know where things are in the process. The second is all the authority sat with one person, which shouldn't be the case, right? For us to be successful, the right people have to be empowered with the right authority to ensure that things can move through in the committee and it's worthwhile. If all the committees, because I can tell you there were a lot more committees than this, and said, does it need to be a committee, or can it be a task force, or is it just a work group? It's a group of people that are working on a project, and let them work on the project. Doesn't mean that they're disincentivized or any authorities taking away. But when we talk about committees, there should be accountability, there should be minutes, there should be a process of moving that forward. So again, I shared this already, but the current process is person dependent. There's no shared decision making, or very little shared decision making in the process. And part of this is improved communication. My commitment to you is we will ensure 2 different things. One is if a committee has had an authority, the new process is not to remove the authority from that chairman or from the committee to make the decision. Those committees will continue to function with the authority that they've had. But those decisions need to be communicated so that we're all aware of what's going on and who's doing what. The second is we will monitor the approval process, and we will ensure that things are being done in an appropriate way. And I don't mean to. I know people maybe get mad at me for using this as an example, but it's a real example that we need. We've addressed. there's a very long process at getting rid of old equipment or old supplies or something like that. And I know one of the frustrations throughout the hospital and with other departments that have to manage a lot of this is junk is just piling up, right? And the reality is, it's not because we can't get rid of it, it's because the committees that were in charge of doing this process weren't meeting in a timely manner to get it done. And so we need to be able to hold those people ourselves accountable to say, listen, there's a process here, we need to follow the process because it's having impact. And it had an impact on us in that a fire was started behind the pharmacy warehouse. Alhamdulillah, was quickly put out. But think about the catastrophic event that could have happened. If that fire wasn't caught in a timely manner, all our drug supplies in our warehouse would have been gone. So committees have impact on real life events that will eventually have an impact on our patients. And so we need to make sure that we're doing things timely, appropriately, and transparently. So the way that the new structure will be formatted is there will be an executive administrative council, which is I think five individuals, chaired by myself, that will only, our main function is to approve high-level things that where the authority level has to sit with the COO. And then there will be five different councils, which will be empowered to make decisions that delegations sit below the CEO's authority. And so these committees will be, these councils will be able to approve them. The other main thing is many of these councils I was the chair of, which again, it doesn't make sense for one person to be the chair of everything, right? We need to have diversity of thought, different perspectives on different issues throughout there. So you can see we've changed some of the chairs of the councils. We still have a lot of committee that, unfortunately, many of these committees are requirements of Sabahi or Joint Commission or regular, MOH requirements or MOF requirements. So we tried to minimize as much as possible, but you can see the structure. There is some interrelation. So, for example, like if hospital operations or MSEC approves something that requires funding, it would still have to interact with the budget committee to allocate that. But at the end, once something comes to the Executive Administrative Council, it should have achieved all of its approval so that it's simply coming to the council to make sure that strategically it fits in with the overall strategic plan to move things forward. The other purpose of doing this is, we talk a lot about succession planning and making sure that we start to develop the next generation. This committee structure should help us to identify potential new leaders, give them an opportunity to lead something so that they can then develop continue to develop their leadership skills. It doesn't help if myself or Dr. Hidayat are chair of everything, and that doesn't help develop people. So this is the new structure that we've rolled out. It's probably, it's still, I think we officially rolled it out before Ramadan, but it's going to take time to get all the pieces and parts in place. But this is our official committee structure now. In order to form a new committee, and for us to minimize that, the growth again of committees, we will have a process that requires committee approval, but I can tell you we will make it very difficult because at the end of the day, most things are either work groups or task force that are time limited with a specific output, right? The other thing is we need to make sure that if you are a chair of one of these committees, we need to make sure that you're diligently managing the agenda so that it's an effective agenda. We'll see if we can get the alarm off. Or it's done for me to talk about committees for now. Quiet. So that's it for the committee structure. This next question and answer. Okay.
Thank you, Mr. Sharif. Now I will ask you, Mr. Sharif, to take some photos with our champions, for sure with the requirements of social distancing. King Fahd Specialist Hospital Executive Administration would like to extend this certificate of appreciation for the efforts in improving performance of outpatient clinics. Mr. Saad Ruwaida.
A little closer. It's COVID now.
Mr. Mohammed Al-Judayman. Mr. Abdullah Al-Khaldi. Mr. Hassan Al-Maqbool. Miss Mona Al-Ghamdi. Mr. Salman Al-Dosari. Mr. Tamer Al-Rubi'a. Miss Abir Al-Mطير. Mr. Khalil Al-Shihri. Now with other champions, King Fahd Specialist Hospital Executive Administration would like to extend this certificate of appreciation based on patient experience measurement program, who got significantly higher than the average physician mean score, which is 86.4%.
Let's read the name because they did.
Okay. Dr. Khalid Sabr, Dr. Adnan Al-Wasaybi, Dr. Abdullah bin Saleh, Dr. Nada Al-Bakri, Dr. Ali Al-Munan, Dr. Abdul Aziz Al-Wasaybi, and Dr. Ijaz Al-Sur. Congratulations to all of them. Now we'll be with Mr. Sharif Hamar and the question and answer of the staff.
Okay, so for the question and answers, my favorite part, since we received so many questions last time, we tried to group them more by category because a lot of them are similar in themes. So in the interest of time, I won't go through every one, but touch on each one of them collectively. So for the first group, it's more about, I'll say travel. Travel that's going on, and I think some of this we've answered since the last quarter. Probably some of this is more clear, but as you know, there was a Ministry of Health memo that said, to stop vacation for those areas that are COVID hospitals or have vaccination centers, all that. Alhamdulillah, we've been able to manage continuing to run the Green Hall and minimize the number of COVID patients, that we've been able to continue to allow, not necessarily at the historical rate, but we've been able to allow the departments that to have vacation. I can tell you that I don't think I've, in the past several months, disapproved one yet. The only thing we've asked the departments is to make sure that if the COVID situation does get worse, and inshallah it doesn't, that we're still capable of providing the operations. And so that's where we've limited the number of people. So for exit entry, the process for getting exit entry is normal in terms of you request it from HR. The only thing that we've been a little bit more due diligent on is the 20 countries that were on the no visit list, mainly because we felt like it was important for us to know who was where. And so we've given the exit entry visas for all of the areas except those 20 countries, so that we could know who was in and out of the country, who was there, to make sure. Because the issue that we've had is we were giving exit entry visas, and we were unaware that some individuals were going, let's say, for the weekend. And our fear was if something got shut down, we'd have too many employees outside of the system. But the process is the normal process where you submit your request to HR. I try to respond within the day. I know sometimes it takes me 2 days to respond. But again, we haven't really denied anybody's request for their leave. The second is annual tickets. Right now, there's still the regulation under the Saudi Airlines that the hospital can't buy the tickets. We have to reimburse. I know that we've been behind in the reimbursement process on the tickets and the iqamas and all that. But finances, we did some rounds this week and heard it from a lot of the staff. So the finance team is working through paying the outstanding invoices that we have to our employees and ensuring that we stay on top of it. So inshallah, within the next 30 days, we should be able to catch up the older reimbursements. We don't have a timeline when the process will go back to the old way. Obviously, it's contingent on Corona and the various regulations that are put upon us. Application for financial annual leave compensation. The question around this one was, why is it that only physicians get annual leave? The reality is, it's not just physicians, it's clinical, right? It's physicians, it's allied, and nurses. The only category that's excluded from that is administrative positions. This is, again, I hate to say it, but it's a ministry regulation. It's not something that we have the flexibility internally to decide to do or not to do. It's policy, and it's important for us to follow policy so that we can ensure that we're consistent with our practices and there's not variability within there. The other one was around assurance that all non-Saudi employees who serve the hospital more than 10 years will get renewed. I think we talked about this last time. Again, this year we've had no rejections. Everything was extended. We've not been able to get commitment that this will happen every year. And if I tell you anything otherwise, again, I'd be lying to you. We know, what we do know is that the clinical staff, there's a lot more flexibility in the clinical staff area than in the admin part of things. So we do have the waivers for the clinical staff, but when it comes to administrative position, each year it's going to be a person-by-person process. I know that creates anxiety in people, and it doesn't give a lot of stability in terms of how to plan your life. But unfortunately, that's the current rules. Our goal as an institution is to retain the great staff that we have, and we will continue to request those exceptions on an annual basis. How to calculate the end of service. I'll take this back to more of the annual increments because the question of how to calculate your end of service is a technical question, and I would encourage anyone that has a question to go to HR. I know they'll be happy to sit down with you and go through the calculation of how end of service benefits is determined. As far as the full end of service payments, I know last time we met, I shared with you that we had some issues with the annual increments for expats for the previous 2 years, that there was a legal case currently going on. Unfortunately, we're at the mercy of the courts, and that case still isn't finalized. And so what we've continued to do for end of service benefits is pay the end-of-service benefits minus the 2018-2019 quantity that was given. Again, it's our goal, inshallah, that the courts will say this money can't be, must stay with the employee, and then we will pay whether the person's still here or HR has, the international bank accounts. We'll pay the difference, but we have to, for now, retain that money until the court case is finalized. We are pushing as much as possible to bring the resolution, because one, I know, again, it's creating anxiety, but two, it's also preventing us from doing the annual increment, because we don't know what the annual increment is based off of. So as soon as we have resolution on that, we'll be able to do the annual increment, and I know everyone, especially, particularly myself, will be happy to put this subject behind us and move forward. So nursing specialties in their, with Saudi Commission with more requirements and increase in license. Again, this is one that, I get a lot of requests from people to make exceptions, but unfortunately, the Saudi Commission has very specific rules in terms of what they recognize as a degree. And particularly as within healthcare, more and more stuff is getting subspecialized. I can't say that the rules are keeping up with the subspecialties. And so we do have people that are going to get certain degrees or going to get certain COVID for last year. Alhamdulillah, we have vaccinated, KFSH has vaccinated over 230,000 individuals, which is a great achievement. We will, June, because of vaccine supplies, has been kind of level, but July there'll be a big shipment coming in, so we plan on ramping back up in July. This will again require a lot of our support, and I know that it's not, I've heard that this is not my job, or this is not where I'm scheduled to go to, or whatever. I understand that, and I know that from a pure job assignment, that's true. But at the end of the day, this is us participating to improve the health of our community, because the quicker we vaccinate, the quicker all of our lives can get back to normal. The quicker we can freely travel, the quicker we can hopefully stop wearing masks, all those type of things. So I don't look at it as I'm being asked to go do something extra. It's really where we are all being asked to do something to help the community to improve the outcomes of the pandemic. And at the end of the day, trust me, it will all improve our lives. So please, when we ask you for your help to go to the Green Hall or participate in something, it's not extra work. It is us asking you to help the community and help our patients, and do it for the right reasons. So again, I appreciate everyone's effort over the past several months. People ask how long will we be at Green Hall. Honestly, that's dependent on us, right? The quicker we can vaccinate, the shorter we'll have to be there. And it's not that we have to get to 100%, right? Ultimately, the goal is to get to the 70% threshold, and then at that point, things can decompress into the primary care settings and all that. But we still have to get to that point. I think the latest statistic that I saw is we're somewhere around 45% vaccinated within the Eastern Province. So we still have a way to go, but inshallah, we'll get there with everyone's efforts. Thank you.
Thank you, Mr. Sharif. My colleagues, for any suggestion or inquiries, please scan the QR code for general staff meeting announcement. You can find it at your email or also at the hospital portal. At the end, I hope very nice and quiet weekend to all of you. Please be safe. Thank you.